Thanks very much for joining us today, Gerry. First of all, can you give us a brief introduction of yourself and your background?
Oh, thanks, Kevin. I'm really pleased to join us. So I'm Gerry Hanna. I'm the new Marie Curie Chair of Clinical Oncology, based a clinical oncologist in the UK system, but now a radiation oncologist based in the Irish system in Dublin. I've literally just left Belfast for Dublin, so it's nice to be joining a really exciting new team around the Trinity St. James's Cancer Institute, which is based there. Previously, I was Director of Radiation Oncology at the Peter MacCallum Centre in Melbourne for 3 years, and prior to that in Belfast, and also Clinical Fellow at the VU Institute in Amsterdam. So I've been a few good places in the world, thankfully, before, but of course, very excited to be joining the team in Dublin and at Trinity, and also the St. Luke's Radiation Oncology Network.
Fantastic. And why did you choose to practice oncology?
Oh, yeah, it's a really good question. So when I was a medical student, to be honest, like a lot of us going through medicine, a number of different areas really interested me, and I really wanted to make it, wanted to do something impactful. So I thought maybe surgery was the right way to go. And I did some of my intern or junior house officer jobs in surgery, and I wasn't so thrilled with the communication style, and I thought there was probably a more humane way to do it. And I was very impressed by a visiting oncologist to the ward. I thought, this is the type of doctor I want to be. So that's why I chose oncology, and I think it's suited me really well. It's a mixture of both, being very much the physician clinician towards patients, but also delivering, particularly in radiation oncology, treatments that can cure, that are impactful, and that are also very non-invasive, and of course that are technologically really exciting, particularly given all the recent changes in how we deliver radiotherapy over the last 20 years.
Brilliant. And can you share some of the latest developments in lung cancer treatment that interest you?
Oh my goodness. I mean, if you look back to lung cancer 15 years ago, we treated it in an entirely different way across all our modalities. If we take, first of all, staging, the initial staging now is EBUS driven, it's PET CT driven. We're no longer using just CT alone to define where the disease is. So we're much better at staging, getting that staging right. That's going to change again. We've seen recently in the seismic study out of Melbourne that, if you do systematic EBUS staging, it upstages the tumor compared to PET in 12% of patients. So staging is still evolving, but I think that staging bit, first of all. And then the diagnostic bit, obviously, we've gone from many people just being given a diagnosis, particularly if they come to oncology, of clinical lung cancer only. So now we're making sure we've got the cell type right, obviously the genomic analysis, and failing that, obviously using circulating markers such as ctDNA, which are now informing our treatment decisions. So staging diagnosis really changed. Surgery has gone to very minimally invasive surgery. And of course, sublobar resections are becoming, more and more utilized as that evidence base has grown in that particular part of lung cancer. Systemic therapy, of course, is very much genomically driven. If you've got a driver mutation, it's about finding the mutation, making sure that you choose the right, drug for that mutation. That's becoming exceedingly complex, particularly in the area of looking at people who have not just one, but maybe 2, 3, and working out how that interacts with, say, other markers such as the PD-L1 status and so on. So I think looking at that has changed considerably. I remember very clearly when docetaxel came out and the median survival had made the 1-year mark back in, I think it was about 2007, 2008. Now we're seeing people live, many, many years, and median survivals sometimes not even being reached in certain studies. And of course, the immunotherapy, does transform what we do, both in terms of outcomes for patients, but also in managing the toxicity of that treatment, which is exceedingly complicated when we see a lot of very novel, toxins that we never have had to deal with before. And it's become its own almost subspecialty within oncology. And of course, if I turn to radiation oncology, we've gotten much better at saying where the cancer is. So particularly in lung cancer radiotherapy, we're able to track the tumor with 4-dimensional CT. We know where it moves. We know better how to shape our fields around that movement inside the chest. We're better able at, stages, as I said, working out using PET CT to inform where we put our actual target volumes, liaising with the respiratory physician to say which EBUS nodal stations should be involved if we've done that systematic staging proposed by seismic. And then in the delivery, we're getting better at every day now. Patients have what we call volumetric imaging, which is done by a cone beam CT usually, but that's getting increasingly complex, We're seeing, develop just HyperSight, which are using much better CT algorithms on the machine to say where the cancer, and that's given us a lot of insight as to what's happening in patients during treatment. And certainly in our practice, we would see that 1 in 10 patients would have their treatment fields change significantly during treatment. In other words, we were missing those patients' targets before. So this is, I think, improving outcomes very, in a very incremental manner over a period of time. And we look forward to novel technologies which haven't fully realized their promise. And I think now proton therapy, particle therapy, which as yet we don't have good, level 1 evidence to say that proton therapy is better than standard radiotherapy, which is delivered by photons. And of course, MR-Linac is in the wings too as well. MR-Linac is where we image guide, or we say, where is the cancer using an MR scan alongside a linear accelerator. Now, in lung cancer, it may not have a lot of benefit. As we know, MR is not good at, imaging the lungs, therefore it may not have the same promise. So there are a lot of technological developments about how we deliver treatment. And then in the actual physical delivery, the beam on or a linear accelerator, there have been new developments such as flash radiotherapies giving very high instantaneous dose rates. And we don't know, the theory is that they may be better at preserving normal tissues, but very potent towards the tumor. We haven't realized that in clinical practice. So there are a huge range. If you take all that development together across the panacea of lung cancer, they're really exciting times. We're also looking at how to do supportive care. You think about things such as prehabilitation, rehabilitation. We've never thought of prehabilitation in lung cancer patients. And you have currently a PhD student looking at that and saying, how might we do this in the right cohort of patients? How do we get patients better fit for treatment and maybe better tumor outcomes? So there is, oh my goodness, Kevin, it's really transformed over the last, say 10, 20 years.
Excellent. And prehabilitation, does that involve exercise or is it?
Yes, so it's particularly at Queen's and Belfast and there are other centres. There's a Canadian group. There's quite a few active groups around the world looking at prehabilitation across a range of tumour sites. We've initially done these in tumour sites such as breast and prostate, where patients tend to be fitter than patients who have lung cancer. And they've shown, benefits to well-being. There have been some suggested benefits to maybe clinical outcomes. They're harder to disentangle from all the other confounding factors that those patients have. So there's certainly a suggestion that, prehabilitation may improve well-being, fitness for treatment, but may improve things such as tumor oxygenation, those type of things that actually might make some of our treatments such as radiotherapy work better. But we've yet to prove that, I think. And I think if we bring it to tumors such as, say, lung, head, and neck, it may have more of an impact than we would ordinarily have seen, say, in the other, less hypoxic tumors such as, say, breast or prostate.
Why hasn't that been proven yet? Is it a case of not having a big enough trial, or? Yeah,
I think in our focus to try and improve outcomes for patients, we've always been very fixated on very clear therapeutic targets or outcomes, and that's where we've invested, be that through say in the UK CRUK funding, through various say grants in the US, or through pharma support. We've never really looked at prehabilitation as being a distinct entity, or even rehabilitation to that extent. So I think it's probably we haven't focused that as and it's probably been it's been a kind of cultural thing in the sense of getting a better drug, which we know will make the bigger difference in the end. So I think it's now time to widen that package out to say, look at the other bits that support a patient around diagnosis, treatment, and of course, hopefully rehabilitation afterwards or survivorship.
Excellent.
Fantastic. And as a radiation oncologist, how has CRT in lung cancer developed over the last 5 years?
I think so chemoradiotherapy and how we deliver it, I think one of the biggest changes that have really taken place, really particularly over the last 10 years, is the kind of move away from giving, neoadjuvant or induction chemotherapy followed by radiotherapy for those patients who ordinarily could have got concurrent chemoradiotherapy. We know from the Operin meta-analysis, that's back to 2010, that actually if you get concurrent chemoradiotherapy, your 5-year survival is 15% for all comers, whilst if you get sequential chemoradiotherapy, it's 10%. So there's a 5% gain in giving that treatment concurrently. And I think slowly but surely that we've been more confident of giving chemoradiotherapy. One of the reasons why we didn't is because very often we presumed that patients weren't fit enough for the combination together. And I think as an international community, as we've reassured each other, that that's safe and good to do, then we're seeing those rates of concurrent chemotherapy go up. So I think the first thing to say is that's definitely, seen a notch up in that way. I think also we have gone from giving straightforward platinum doublets to being a bit more tailored around the pathology. So, say for instance, PEM carbo is frequently used in different areas. And I think the other huge game changer has been the addition of adjuvant durvalumab after chemoradiotherapy in stage 3. That's, of course, from the Pacific study, which showed a significant improvement in median, both progression-free and overall survival. That's giving chemoradiotherapy first. If there's been no progression immediately after that, then given a year of adjuvant durvalumab. And that has been very transformative, I think, in terms of outcomes, I said before. The very interesting thing recently from the European Lung Cancer Congress in Prague was that we saw in the Pacific 2 study, which was giving immunotherapy concurrently with chemoradiotherapy, that concurrent durvalumab didn't lead to an improvement in survival outcomes. And that's been the source of a lot of debate recently. Maybe that concurrently doesn't work so well. Maybe having the concurrent chemoradiotherapy gives an immunopriming effect that's then picked up by the adjuvant immunotherapy. So I think the biggest change is that particularly in stage 3 is that adjuvant immunotherapy. We have also seen presented at the World Congress in Lung Cancer back in September in Singapore, the iSaver, that's from Joe Chang out of MD Anderson. And that study gave 4 cycles of adjuvant immunotherapy after stereotactic radiotherapy for stage 1. And again, there was a significant uptick in survival. And that's really, really interesting. That's a group that we wouldn't normally think of giving immunotherapy to. The outcomes of that group are quite good. But here is an adjuvant immunotherapy, which is improving it yet again. That to me is also a very interesting signal. And they all kind of point to that there is some sort of immunopriming effect with radiotherapy that's picked up with radiotherapy that's then picked up with immunotherapy afterwards. So, it's a very interesting changing field in that way.
With the combined use of CRT and immunotherapy, how do you approach interpreting scans post-CRT?
Yes, I mean, interpreting scans after radiotherapy is really, really complicated. We see a lot of confounding factors. If I kind of back up a little bit to taking out not CRT, but going back to stage 1 lung cancer. Stage 1 lung cancer, we had given stereotactic radiation, we see a lot of fibrosis or changes sometimes. It sometimes looks like pseudoprogression. Even the PET scan can be hot 6 to 12 months after treatment. So there's a lot of confounders, in interpreting the scans. And I think the best way that this is done is obviously in an MDT setting where you actually got a discussion with, the various imaging partners, be that nuclear medicine, be it radiology, and of course then the radiation oncology. I think this is it. And there's some, in that particular group of patients in stage 1, we look at certain factors. So for instance, where we treat in the radiotherapy, the beams come in almost, perpendicular to the body. So if you've got vertical growth, i.e. above or below the tumor, that's not due to pseudoprogression of the tumor, that's probably real progression. And there are kind of little rules around that. And we published a review in that in the International Journal of Radiation Oncology Biological Physics. That's back in 2021. That says, what are the features such as that you might look for to try and interpret the scans? Those principles still hold true then for stage 3 post-chemoradiotherapy going on to immunotherapy. I think one risk we have in that stage 3 concurrent chemoradiotherapy group, particularly if we're thinking of adjuvant durva, is not to overinterpret, what is pseudoprogression after chemoradiation. So my practice is to give patients the benefit of the doubt. So if they really haven't got clearly new disease elsewhere outside of the radiation field, I will tend to call it stable disease at that point. And if it's appropriate, get those patients onto adjuvant durva, rather than actually, exclude them from the opportunity or chance to get a go at durva. You'll always be doing a scan 3 months down the line anyway, and it's looking at serial progression scans is probably more important. So I think giving patients the benefit, it's very important in those early stages. In the lung, you can obviously, when you give chemoradiation, you can get little bits of collapse. There can be elements of radiation pneumonitis, and it's very hard to pull out what is radiation pneumonitis from standard, progression or indeed other infective changes around that. And don't forget, always be aware in patchy changes in the lung. One thing we have to be very careful in chemoradiation, we know now that there's a greater chance of opportunistic infection, particularly the use of steroids, other bits. So we think of pneumocystis jirovecii pneumonia, previously known as PCP. We do know there's a significant instance of patients getting PJP pneumonia, post-chemo radiation. So you have to be careful those patchy changes, that they're not just infective changes and not radiation pneumonitis. So our approach really is in those patients is, particularly if the lymphocyte count is very low, less than 0.5 in our reference lab, we will give sometimes prophylactic cotrimoxazole to try and prevent PJP and prevent those chance changes. If we think there is a significant chance of radiation pneumonitis, we will get them early on to oral steroids and make sure that that doesn't get bed in very quickly. And defining radiation pneumonitis is really challenging. It's a clinical picture, obviously shortness of breath, but a cough, wheeze, but also those patchy kind of inflammatory changes on a CT scan, and that makes it very difficult to interpret. In the longer term, we used to worry about particularly patients on immunotherapy. Is there pseudoprogression happening? Now, there were a lot of reports that pseudoprogression was quite common in CT scan findings, particularly after the first couple of cycles. It still exists, but it's probably less common than we thought. But again, I think the rule of thumb is, unless there's a really good clinical reason to stop or changing the treatment plan, I think keep going into earlier imaging. So maybe don't do the scan, maybe do it after 2 cycles or after, say, 2 months rather than 3 months. That type of approach to treatment.
Yeah, and I've heard the term cloudy scans before. Is that what you're referring to? When
Absolutely. Well, it will very vague, so you get interstitial changes, or it can be, not necessarily a defined area of consolidation. Consolidation is great because you can see it there, buncograms, you can clearly define it. Of course, once you've got consolidation, what does it actually mean and what's the cause of it? But those kind of very patchy changes can be radiation pneumonitis. They could, of course, be an opportunistic infection, as you said, and they tend not to be progression necessarily, not unless you're dealing with somebody with a multifocal disease, and then you're in a different ball game entirely.
Okay,
very good. You gave some practice or guidelines, but is there any other emerging best practices or guidelines for interpreting scans that you would like to share with our listeners?
I think we mentioned obviously our publication in the Red Journal, which is really around stage 1. That to me in clinical practice is the hardest area, saying, is a lesion stable 6 months, 12 months after radiation for stage 1 lung cancer? And they very clearly should, define those bits, like those key bits about the superior and inferior growth. If that's present, that's much more likely to be disease than not, And I think also progression outside of the treatment field is also, and you have to be very concerned about that too as well. So I think that for stage 1. For stage 3, we're really stuck with the ASCO imaging guidelines back in 2020, and we do need to kind of think about how do we, update those, how do those, but it's very hard to define it along to give very clear examples. And I think it goes back to the multidisciplinary team. Those members come together to say, look, what are the likelihood? What is the pattern of disease? Where did the radiation oncologists deliver the field? What type of delivery? Was it fixed field IMRT? Was it a VMAT? And there are different patterns of pneumonitis we'll see with both of those. So it really is that team discussion and getting that kind of, and in the end, it is a little bit, to some extent, of a clinical experience that actually kind of delivers the result in the end. And of course, time is very often the best diagnostician in those patients. The serial scans, what's the pattern as you go along?
Excellent. Thanks for that, Gerry. And could you tell us a little bit about some of the research work you're involved in?
Yes. So you mentioned, so one thing we've been very interested in Belfast, and we have a fantastic fellow called Jared Walls, who's been doing a lot of work on cardiac structures. We're looking to see which part of the heart is, sensitive to radiation the most. And we've done a bit of work looking particularly at a very kind of, left out substructure called the pulmonary vein. Other groups have shown that base of heart has been very important for cardiac toxicity. But what we have shown very clearly is the radiation dose to the pulmonary vein is very linked to your risk of developing arrhythmias such as atrial fibrillation afterwards. And we've created quite a large database of curated patient scans, outcomes, and so on, that also include cardiac risk factors to try and tease out those other, predictors of coronary disease. And in that, one very curious finding is that we saw that patients who were in a higher dose statin, had a much lower risk of a radiation-induced cardiac event after definitive radiation, curative radiation, but in the treatment of lung cancer. So maybe statins might be protective also against radiation-induced heart disease. That's been one very interesting bit, and we're beginning to interrogate that, not just in our clinical database, but in our preclinical models using our small animal irradiator. And we're looking to see, can we actually say, number one is, what are the determinants of radiation-induced heart disease, and how do we prevent those, either by, through chemical means or by adapting radiation plans. The other two bits I've been involved with the Pertain study, which was a really interesting study because it was through the International Atomic Energy Agency and the IAEA. Very often run large projects in low and middle income countries. The premises were always to try and to improve the quality of radiation, to share best practice, across the globe in radiation centres. And in that particular study, we looked at the impact of a training intervention and the use of PET-CT for defining radiotherapy target volume. We saw a significant improvement in survival between two different cohorts at before and after the intervention, and that's very impactful. It's the first time we've ever really shown that doing better quality radiotherapy and using PET has improved the outcomes for patients. It's not a randomized study, but those studies are very ethically hard to do. That to me, and I really enjoyed that work. It was very collaborative. We learned a lot from each other, and we hopefully made a big impact, not just to that evidence base, but also to the quality radiation in a number of different countries that we were involved with. The other clinical study that I had been involved before in Australia was the Concord study, and Concord's a really novel study. Concord was set up by CTRAD. CTRAD is the radiotherapy translation group of NCRI. So basically, it's a collaborative across the UK, and it set up this what really is a platform study, looking at bringing novel drug agents into combination of radiotherapy. One challenge we have is that we develop drugs brilliantly for sole use or advanced disease, but we're very bad at using drugs and getting them licensed and approved alongside radiation therapy. A lot of reasons for that. One is we as a radiation oncology community come too late to the party. We don't use the drugs early enough in the developmental cycle. The other issue is that big pharma companies obviously don't want to take a risk with radiation with their beautiful new drug that works really well on its own. So there are a lot of barriers. We had to do a lot of work with pharma partners to really try and say, can we please use your new agents, which look very exciting, for what there's good mechanistic, reason to use them alongside radiation. So in Concord, we kind of set a few principles. One is we had to have very good preclinical evidence that there was an enhancement in therapeutic benefit for treating the tumor as compared to surrounding normal tissues. That was quite a novel bit of work, and we've done that at a number of different centres. In Belfast, we looked at the ATR inhibitor that AstraZeneca had been using. We also said then that there had to be, we had to kind of create a cohort to say what is the current outcomes and toxicity in patients who are getting radiation alone. That was challenging to set it up. So we have a very interesting phase 1 study where patients are, randomized in 3-to-1 fashion to radiation and drug in a dose escalation, opposed to radiation alone. And then that's each of the arms. So we're creating this very big cohort of a reference group to compare the drug and radiation group with. The radiation group is we're using a Bayesian type design whereby because the one challenge you have in radiation, some of the toxicities are very late. If you take radiation pneumonitis, it can be 3 or 6 months, even a year down the track. And then in that Bayesian design, you're adjusting the odds ratio of the risk of toxicity back to the current dose level. So that allows us to keep recruitment going, but also to be safe and also try and get some of the dose escalation done in a safe but also timely manner. So it's really a very novel study. It's open at 10 experimental cancer medicine centres across the UK, and we've already completed phase 1 for RMA, which is the PARP inhibitor from AstraZeneca. And we're looking, there are 2 or 3 other arms currently recruiting. That's currently being led now by Corinne Faber-Finn and Alistair Greystoke. That was the other design thing. We very much put a radiation stroke clinical oncologist alongside a medical oncologist to have them as a pair, both in terms of chief investigators, but also in each of the units we're running that we actually have co-ownership from both oncology specialists together, which has been a really brilliant partnership, and I think has really kind of set the standard for how we might do drug and radiation combination studies. Of course, the question is, once we get through the phase 1, if it looks promising, how do we take that next? And that's the challenge a little bit, whereby I think in all our clinical studies, we're seeing the challenge of recruitment, the challenge of, very tight and narrow, selection parameters for patients that make it harder and more challenging to recruit. So it's not by any means, finished. We've started at the beginning, but now we need to deliver those later phase studies coming out of Concord.
Fantastic. Great. And what do you see as the biggest challenges facing the field of oncology today?
Oh my word! I think one is I think we're the victim of our own success. So I think one problem is, thankfully, patients are living longer. Patients are getting cured. You know, in my own practice, we're seeing patients come back who were treated with bladder cancer 5 years ago or had something else, breast cancer treated, and we're seeing them now getting a second cancer, which is unfortunate, but actually it's really great they're living to get those second cancers in a way. So this is the challenge, that we actually are seeing, you know, what is not just a linear growth in cancer, but probably slightly getting towards exponential. So that's probably a good thing in some ways, but obviously a challenge for health resource. I think the challenge also is we have so many new systemic therapy options, which are brilliant, but our challenge is getting the resource to deliver those. And it's not just the drug cost, it's actually the people to do the assessments, the oncology team, our nurses and our pharmacists to make up and deliver the treatment. And those, having the staff resource, I think, is a real challenge. And that's not just a problem in Ireland or the UK, it's a problem globally. And I think, we need to emphasize a little more. We really need to expand our training and our capacity to deliver this, or at least find a novel way to do it. We can't just keep doing the same old thing and expect different results. So we have to do something that's going to be very different. We've seen in some drugs, if you go back to Herceptin, the ability to self-deliver that subcutaneously in the past, and maybe it's getting that the ability to kind of patients to somehow make it easier for patients to receive systemic therapy, I think is one very big challenge. So I see that capacity issue, using my previous clinical leadership hat on, as a big challenge for the future in our specialty. For radiation oncology, the big challenge is gathering the evidence. So we're very good at doing these little tiny incremental gains in radiation oncology. We're very bad at showing that they actually make a real difference to patient outcomes, both in terms of survivorship or toxicity. And I think we have to think more innovatively around clinical trial design and say, how might we do this better? And I think one thing we're getting to think about is, should we really be using real world data and considering patient-reported outcomes in a much more, embedded way in clinical practice, and very much more a bit akin to, how we would do in a clinical trial, and making that our new kind of standard evidence. We haven't really worked that through as a community, but I think given the fact that it's these small annual incremental gains that get implemented without actually evidence, we need to start doing something to say this is actually better, or it may not be better, and therefore shouldn't be pursued. So if you take the story of protons have slowly evolved over the last 30 years, which is brilliant, but actually it's very hard to gather the evidence and say that they are better. And a big, large randomized phase 3 is not going to deliver that in radiation oncology. I don't think so. So I think those to me are the two big global challenges for what we do. Of course, there are many countless others, but that's the ones that kind of occupy my mind a little bit.
Yeah. So you mean like one is survivorship and two is the gathering the evidence.
I think so, in a meaningful way. Yeah.
Yeah. And do you have any ideas on how to address those two? What would, in a perfect world, what would be the solutions?
Oh my goodness! So, well, I don't know. We're always looking for the magic bullet, aren't we? In cancer medicine, in a way, there's an oral drug that is very easy to take, and of course, and ideally doesn't have too many years of treatment. But of course, the length of treatment is increasing. So I think if you take, for instance, immunotherapy, one of the great questions might be: do people in stage 4 disease, do they need to be on immunotherapy indefinitely? Can we at some point stop it? Can we reduce the number of cycles? And that's, of course, those are challenging trials because they're not commercially attractive to do if you can, from a pharma perspective. But I think once we see drugs go off patent and those things change a little bit, I think we'll see some of those kind of trials be done elsewhere. We saw it with the breast cancer drugs, Herceptin. We saw, kind of the 1 versus 2 years of the HERA study, and of course we saw the FINHER study showing a 3-month duration might be okay. So I think that we're going to have to rationalize what we do just to be able to deliver the fantastic panacea treatments we can deliver across our tumor sites. I think innovative ways of delivery is a real challenge because, a lot of the very complicated agents such as immunotherapy, they're always going to be denatured by, GI absorption. We're not going to be able to get those as a tablet form. Whether they can be given easily subcutaneously, that would be a good thing to do too as well. So I think that is a definite and distinct challenge.
Excellent. And then final question. So AI in oncology, do you see any opportunities for AI in oncology?
Oh my goodness, so many, Kevin. The hope is they don't replace you or I, but that's a different matter, But I think we're always worried about AI replacing. But I've no fear of that because we're human beings. We require human interaction, particularly whenever we're vulnerable with cancer diagnosis. And I think that bit we'll always need clinicians to guide us. And I think our decision making more generally in oncology, I can see a thing where we input a range of variables, or our EMR system does that for us, and the AI tool picks it up and then delivers, what is a guideline recommended. And it may involve not just patient factors, but it'll be the genomics of the tumor, pattern disease. It'll be pulling from, the theory was that it would pull from a number of different factors, including, of course, a PubMed library. Perhaps you could see that being almost the kind of the what I call holy grail, so to speak, of oncology decision making. But it'll always still be guided by the clinician and the patient factor, and of course, ultimately, then patient choice. Do they want to accept this or not? In a way, I think that's more ethereal, but we're getting there eventually in other parts of medicine. Immediately in radiation oncology, we're already in Dublin using AI to delineate where the normal tissues are to speed up our auto outlining process. So where a radiation oncologist and their team, that includes obviously radiographers, technologists, when we get a patient scan, we have to go around and say in every slice, where is the tumor, where are the normal tissues around that, so then we can use our computers to help plan the tumor, the radiation plan around the tumor and minimize the toxicity to normal tissues. So we are already using AI to define where the normal tissues are, and that's really, really excellent. What the advantage of AI is that if you think, all of us have slightly different anatomies, the shape of my thorax will be different to yours and so on. And a standard algorithm doesn't deal very well, but once AI learns and it uses all the previous scans in its repertoire to try and learn from that. So it's been successfully implemented. It's clinically safe. It's running very, very well. There are about 6 products in the UK. They're actually even being NICE assessed and NICE endorsed for clinical usage. So AI is here already in what we do. And it's not to replace us, but it's to speed us up. And I think that's a brilliant thing. I think it makes that treatment pathway shorter for patients, more accurate, and safer. Can only be a brilliant thing.
Brilliant.
Fantastic.
Thank you very much, Professor Hanna. Really appreciate your time.
Thank you.
Thank you so much.
No, really, really enjoyed it. It's been a good kind of rollover, all the good things we've done. There's so many challenges you have to go in lung cancer, but I think we're beginning to shift the dial. I think we'll see if we can see in the next 10 years the same seismic changes we've had in the last 10 years, I think it'll be really brilliant for patients. Thanks, guys.
Fantastic.
Thank you.
Thank you.
Thanks for having me.